get a full body PET scan. And I can't tell you how many times I have to still fight insurances to allow that. It's a shame, but that's like the least favorite part of my job. But we have the guidelines, and now ECD is included in the NCCN guidelines, which are, if your doctor doesn't know and you're giving you pushback, you can tell your doctor that please, you can use the NCCN guidelines, National Comprehensive Cancer Network guidelines, and that were formed 2 years ago as well. And the payers look at those guidelines and generally approve the PET scan. And MRI of the brain and heart MRI are also recommended at first diagnosis. Other important change and important information is to check for the BRAF mutation and mutations beyond BRAF. Now you can do it in one of two ways. One is you can start with the BRAF mutation and say, okay, well, let's see if it is positive or negative. If it is negative, let's look for the other mutations. But sometimes you only have so much tissue available for doing these testing. So our practice is to just send for a broad panel right away, because it takes, 7 or 8 slides, 10 slides, and you can just do a broad panel for all these mutations. And now there is RNA testing for looking for gene mutation fusions as well, which can be targeted by pills. Over the years, many drugs have been used in histiocytosis because, like we said, that it was not recognized as a cancer for a while. And I tend to think of it as a conventional agent bucket and a targeted therapy bucket. Conventional agent is everything from immunotherapy, chemotherapy, anti-inflammatory drugs that rheumatologists use, and some other non-specific treatments. And targeted therapies, for the most part, are BRAF inhibitors and MEK inhibitors. But now we are seeing new inhibitors are being used and coming on the horizon, CSF1R, ALK inhibitor, and so forth. And those are seen less than 5% of the cases. What is the recommended treatment approach for ECD? When we see an ECD, an individual with ECD, first thing that is important is to evaluate. Of course, we see what organs are involved. Is there any major organ involvement, brain, heart, that could cause problems if not treated? If there are a very small subset of patients who could have just isolated bone involvement with minimal symptoms, or like something around the kidney with no problems at all, that you can choose to just watch closely. But that does not mean you say, well, you're fine, you don't need to see me again. It actually means, no, we will do a scan again to assess the tempo of the disease, how fast it is growing. But for the most part, most patients with ECD require treatment at diagnosis. And the way to think about now is targeted therapy is the #1 way to go about it, because chemotherapy and other treatments have shown mixed responses. So if somebody has the BRAF BRAF V600E mutation, I tend to choose BRAF inhibitor frontline. Zelboraf is FDA approved now, so that's not been a problem. But one of those conventional agents like interferon and anakinra can be considered if Zelboraf is not tolerated, not available. There are other issues. There are even countries where you can't get access. So those treatments can be used. If you find other mutations in the MAP kinase pathway, you can use a MEK inhibitors. The common one that was used now and is under FDA review is Cotellic or cobimetinib. There are very rare other mutations and fusions, ALK, RET, NTRK, which we have seen, and you can actually use very specific inhibitors. Now, these are off-label treatments, except vemurafenib, and you have to fight with your insurance or the drug company to get the drug, which we have been successful at times. But there are occasions where we see somebody and they are sick, they have a lot of symptoms, and these genetic testing can take weeks to come back sometimes. So we can potentially start them on empiric MEK inhibitor like cobimetinib, because Cotellic will work even if you have a BRAF mutation. But the BRAF inhibitor will not work if you don't have the BRAF mutation. So Cotellic or other MEK inhibitors can be used if that is the situation. And now remember, if there's a clinical trial, please inquire, because that should be the way to go. If that makes sense, please ask your oncologist about a clinical trial when you see them. Once treatment is started, that is not all, because we need to watch A, for are you responding to treatment, and B, what side effects are you having to treatment. In terms of following the disease, we recommend doing a PET scan again to see the brightness, if the brightness has gone down. Because if we just do a CT scan or an MRI, those cells may be dead, but they may still look abnormal under those scans. But we want to see if they're active or not. And then endocrine evaluation is important in parallel. Supportive care, pain management, depression, those symptom management are important because they may not get better, even if ECD is responding. And then other testing, other things, you may need to see a dermatologist more often if you're having a side effect of skin. You may see an eye doctor if you're on Cotellic and so forth. ECD involves many organs, as I have shown. So it is very important to have multidisciplinary care. I cannot overstate this. That is why the role of the care centers of expertise comes in, at least at the initial evaluation, is to have multidisciplinary care. So we started the histiocytosis working group when I was at Mayo Clinic, and then I moved to UAB. So we actually expanded that group. And so we meet twice a month now. We review cases, we have research projects ongoing. And so, more and more folks are joining our group. And that was part of the image I showed. That article came as a part of these efforts. So dedicated histiocytosis team is very important. I'll spend a few minutes on unanswered questions that we need to address. And some of these may be brought up in the other talks. The one question that I get asked often, previously we were struggling with finding treatments, and now we get often, which is a good question, can I stop the treatment? Now the treatment is working, but it's causing me symptoms. Can I take a break? Can I stop the treatment? And the best approach is unknown. There is no study that addresses this question directly. There was a study from France, the French colleagues, that showed that if you stop BRAF inhibitor, 75% of the cases will have disease coming back on scans within 6 months. Now, provided that study was not planned to answer that question, but the discontinuation rate is real from side effects. Lower dosing is one thing that we have used, and we have published on this, that may be effective in a lot of cases. So it's important to discuss with your oncologist. What I don't want people to be doing is to just stop the drug on their own. I would just talk to the oncologist. I've had cases where we have done drug holidays after a couple of years for a little bit of time if things are stable, but you have to have very close monitoring because every patient may behave differently. The nice thing in that study was that when the BRAF inhibitor was restarted, the response was captured again, so which is good. But you got to discuss it with your doctor. The other area of interest that I have, which is a major interest, is we really don't know the long-term outcomes of ECD, right? 10 years ago, 20 years ago, the main concern was, well, will I die of ECD? I think we are doing much better than we had done in the past on the mortality from ECD. But what my interest is, what is happening in the long term with these patients. In other cancers, which are highly curable or treatable, like lymphomas, we are seeing long-term late effects, and people are dying or having health problems other than the lymphoma or from the treatments. So as the survival of patients with ECD improves, and these patients are on these long-term pills, cancer treatment pills, they may be at a risk of developing chronic health conditions and other problems related to the disease itself or the treatments. And then ECD, as we know, can involve many organs. Organ dysfunction is prevalent. So because of all these things, you can have mortality from other causes, which needs to be investigated. Individuals can have extended or more healthcare needs that can reduce their quality of life, can have chronic pain, psychological issues, and so forth. So this growing survivor population need to be met as well, because I get now this question is, okay, what is next for me? I'm on this Zelboraf for 5 years. What's going to happen, doc? What do I look for? Am I just, I can do whatever, I'm fine. Should I stop this pill? What's going to happen? And we don't have the answer to that. We really don't. And I think we need to address that in parallel because we have found good treatments. So to address that question, we are leading a national study called as the histiocytic disorder follow-up study to address the survivorship issues. It's a partnership between UAB, ECDGA, Histiocytosis Association, The goal of the study is to understand what is happening to the patients after they are diagnosed with histiocytosis. And it's directly going to ask you. So it's formed based on a survey that you have to fill up. And this will really help us develop guidelines for long-term care of patients, as has been done in bone marrow transplant survivors, lymphoma survivors, and so forth. And so I would encourage all of you to participate in this research study. There's a small gift card for your time. There is an email address here, and we can provide it to you afterward that you can, you have to just do it from your home, fill in the survey, and that's going to help and answer those questions. So what are the takeaway suggestions? Please know as much as you can about your ECD, know about what organs are involved, what are the mutations. The other thing to remember is if you develop a new symptoms, if something new comes up, be ready to re-examine everything and say, hey, something else is going on, doc. Think about other things. Other problems can happen in an ECD, in a patient with ECD. So, so it is the nature of things sometimes. So you got to re-examine the treatment approach and the history again. I cannot, again, I have to say this again and again, please treat depression and anxiety. I have to literally sometimes with my patient, I'm like, yeah, you are depressed, you need treatment for the depression. The treatment of ECD may not be enough to fix that aspect. And it is real in people with ECD and other histiocytosis. So please get care for that. Your oncologist is not a very good psychiatrist, I can promise you that. They may need one soon, but they are not a very good psychiatrist or psychologist. Very important to get second opinion. Dr. Gupta talked about telemedicine, which is now accessible. I have, for example, the state licensing issue plays a role in it. So I cannot do telemedicine for someone in Ohio, but I can do it in Georgia, I can do it in Tennessee, Florida. So you have to just, the doctor needs to have a license in the state practice. But look at second opinion, at least if you can travel once. I think it is worthwhile sometimes when patients come to an expert center with multidisciplinary care. Even if the answer is no, you're doing everything right, you're fine, that's reassurance. That's important too, I think. And please, 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 as Dr. Gupta mentioned, please get involved in research because it's a partnership. Like I mentioned before, please get involved in the registry, in the survivorship study, and other studies that come up. All of us, when you come, will probably request you, beg you to give a sample of your blood in our freezers. We don't sell them, I promise you. We actually collaborate on doing studies. So it is very important for you to participate. It's very rare disease. So we don't have thousands of patients to conduct these studies there. We have many other projects going on. We have the histiocytosis working group meeting, which has a tumor board. We got the NCCN guidelines out, which I think one of the biggest victories for patient care. We have many DNA, RNA-based studies, blood-based testing to look for, can we stop targeted therapy early going on? We are trying to find novel targets beyond BRAF and MEK inhibitor because we are realizing that they may not be curing the disease. And patients are often stopping the disease stopping the pills. They're not able to take the pills for a long time for side effects or financial reasons and so forth. So we are trying to find other targets. We are doing good, but we need to do better. And then my particular interest is in the long-term effects, late effects, survivorship, and also to how we can diagnose histiocytosis early on. And can we combine some sort of chemotherapy and targeted therapy to cure, or at least put sustained remission without treatment so that the side effects and complications from the treatments can be dealt with better. And then we have a registry. We have funding for that, where if you come to our clinic, we'll request you to consent for a blood sample and so forth, and we are doing studies on that. So that's all I have. I would like to thank patients and families. All of you, some of you have actually participated in these studies and other studies. None of this is possible without that. Thanks for your advocacy. Thanks for traveling to us, and it motivates us to do more and more research. I have mentors and collaborators throughout the US and actually outside. And this is my research team. I would like to thank ECDGA for always thinking of me when such opportunities arise, and all the other funders. And thank you for your time and attention.